So I would be talking to you about role of intracameral moxifloxacin in prevention of post-cataract surgery and endophthalmitis, and particularly about the randomized controlled study that we have done on 60,000 patients. There are no financial or proprietary interests, and it has been decreasing over the last decade from 1 to 0.05 to 0.1%. And of course, prophylaxis is important preoperatively with topical antibiotics, povidone iodine installation in conjunctival sac for 5 minutes, which I think is the most important tool that we have today. Intraoperatively, intracameral antibiotics, and postoperatively also the topical antibiotics have to continue. In the recent studies, it has been shown that in India, gram-negative infections and fungal infections are more important as compared to coagulase-negative staph, which occurs more globally, but staph, both coagulase negative and staph aureus, are the commonest organisms for which measures have to be taken. In 2021, AIOCMTC4 endophthalmitis prophylaxis survey, 66% respondents, they said that they use intracameral antibiotics, and 80% believe that commercially approved intracameral antibiotic is important, and if reasonably priced, this would increase adoption of intracameral prophylaxis to 93%. These are the four drugs which can be given intracamerally. Each has its plus and minus. With moxifloxacin, the advantage is that the preparations are available commercially. There's wide spectrum of action, and it works on concentration dependent killing. The very first trial was done for intracameral antibiotics was by ESCRS, and they clearly showed that there was 5 times reduction in endophthalmitis after looking at 16,000 plus patients, and advocated the role of cefuroxime. But cefuroxime to make was difficult because it has to be compounded in pharmacy, and also because of the emergence of the resistant gram-negative isolates. Vancomycin has also been tried intracamerally, but there's a risk of hemorrhagic occlusive retinal vasculitis, and so that is why people have given up its use. And intracameral moxifloxacin, preservative-free, is the one we are looking at, is given 500 microgram per 0.1 ml. If you look at the efficacy in 1 lakh plus patients, a retrospective study by Arvind Eye Hospital did show that there's 4 times increase in the patients undergoing SICS, and likewise 6 lakh plus patients, they did show again that it decreases the rate of endophthalmitis 3.5 times. Whenever you have a PSCR, the chances of endophthalmitis rate increases, and in their study it was by 7 times, and again moxifloxacin helps to decrease it to 0.21% in cases where PCR is there. It is quite safe because there are no adverse events reported on visual acuity, IOP, endothelial cell loss, pachymetry, or AC reaction. And this was the first survey that we did in 2017, which concluded and which highlighted the fact that there were people who were using subconj antibiotics in our part of the in the various parts of the country, as opposed to the ASCRS survey where they did not use any subconj antibiotics, and also moxifloxacin was being used more in the ASCRS survey as compared to the AIO survey. This is the only randomized control trial but does not meet the statistical significance because the power of the study is low in 3,000 plus eyes, which again did show that endophthalmitis decreases after intracameral moxifloxacin. This was the second survey we did, and again we found that from 40% in 2017, people have increased using it to 58% in 2022. So most of the existing studies are retrospective and non-randomized, and so we wanted to see in a randomized control study with good power of the study, what is the role of intracameral moxifloxacin. So the total sample size was 60,000, and 30,000 were recruited in each of the groups from 3 tertiary eye care centers, including Sadhguru and Tirupati Eye Center. And ethical approval was obtained. The phacoemulsification was done. The various parameters were evaluated. In 30,000 eyes, intracameral moxifloxacin was used, and in other 30,000 eyes, moxifloxacin was not used. Phaco was done alone. Post-op regime remained the same in both the groups. Whenever endophthalmitis occurred, protocols were followed which are standard. And in terms of the mean age, gender, visual acuity, IOP, endothelial cell density, central corneal thickness, Both the groups were well matched and there was no difference. Also, in terms of the incision size, type, location, IOL, optic, haptic size, position, wound closure, as well as the posterior capsular rupture, whether absent or present, both the groups were well matched. We did find that 6 cases in the group where phacoemulsification with intracameral moxifloxacin was given, and 16 cases in which it was not given had endophthalmitis. So the odds of having endophthalmitis was 2.5 times as compared to the control group. As far as the microbiology was concerned, 2 cases in the intracameral moxifloxacin and 6 in phaco alone were culture positive, and also there was resistance to moxifloxacin in 2 out of 7 cases within the phaco alone group. Now, as far as the visual acuity, IOP, endothelial cell loss, central corneal thickness, central macular thickness was concerned, in both the groups it was well matched, which means that intracameral moxifloxacin was safe in terms of these parameters. So this study was done using Moxicip from Cipla, and we are thankful to them for providing this. And having talked about moxifloxacin, the ASCRS advisory is important because it clearly says that you have to use the correct concentration and the correct dose. Otherwise, there may be a problem of TAS. 0.1% is not available in India, 0.5% is only available, and we recommend 0.1 ml of this. 0.1% is available in US, and 0.1% if you use in increased concentration, then that can cause to TAS, as anecdotal reports have been reported. So to conclude, intracameral moxifloxacin is safe and efficacious in prophylaxis of endophthalmitis after cataract surgery, but of course you do have to give pre-op and post-op topical antibiotics. Thank you very much for your kind attention. We don't make point. We don't use 0.1%. We are using only from. No. Thank you.